Okay, we will start the last session. I'm Dr. Jason Cheng from Taiwan University Hospital, and also co-chair with Dr. Jennifer Wu from MGH. This session is challenging cases for GI cancers, and we first have a submitted abstract and was awarded with the oral case presentation. So we will first have the oral abstract presentation award first. That's by Dr. Zhou Jiahui. She submitted the HCC case and has been evaluated and was awarded with this oral presentation. She's from Dalian Chiji Hospital. So congratulations, Dr. Zhou, and you may first present your case.
Sorry, I have to use my microphone. First of all, I would like to thank the organizer to give me this opportunity to present a challenging case here. I'll start the case now. This is Mr. Wu, a 69-year-old gentleman. He was initially presented with progressive abdominal dull pain for 2 months, associated with poor appetite. He visited a local emergency department initially, and a huge liver tumor was found on the CT scan. Then he visited our hospital for a second opinion. For the past history, he had chronic hepatitis B and ankylosing spondylitis operated 20 years ago, and now need PRN painkiller. He had alcohol consumption for about 2 to 20 years. He had family history of colon cancer. On physical examination, his height is he had a shorter stature, and the weight was 58. His performance status was equal 1, and the abdomen showed abdominal mass about with tenderness. On the lab study, we can see he had lower albumin level and ST elevation, ALT elevation. The child Pugh score was 6. On the triphasic CT scan, we can see at the initial diagnosis, there was a right lobe hepatic tumor, size 12.5 centimeter, and the right portoventral invasion with no lymph node involvement or distal metastasis. Here's the tumor showing early enhanced and early washout. So the diagnosis for this patient was hepatocellular carcinoma, clinical T4 N0M0, stage 3B, BCLC stage C. According to the BCLC staging, the patient had advanced stage HCC, and at that time, the standard of care will be sorafenib, and we also consult our surgeon and interventional radiologist, but resection and TACE were not suggested. So we plan to give this patient radiotherapy and applied the sorafenib for this patient. Before radiotherapy, we did the complete blood test and the serology study for hepatitis. This patient had chronic hepatitis B with E antigen negative, core antigen positive. And we also did some, we also have some check on some parameters like CHARPS score, ALBI score, and MELD to estimate the patient's liver reserve and also assess the risk of hepatotoxicity after treatment, and also predict the treatment outcome. Here show you the dose distribution of the radiotherapy. During the CT simulation, we obtained 40 CT for him, And the prescription dose for this patient was 60 gray in 30 fractions. You can see the target volume, PTV dose was 60 gray. Here's the CT scan from axial and coronal and sagittal view. And this is the schedule of treatment. In this case, we use the method of modified simultaneously integrated boost. Inside the tumor GTV, we control a SIB volume to encompass all the most of the central necrotic regions, and we escalated the dose up to 5 gray per fraction and given alternative day to achieve a BED 123 gray. So the 5 gray was given for 10 fractions. During the treatment, we do daily combine CT to check the position. This is a DVH. I display the selected curve for some organs only, and on this DVH, you can see the PTV for this. The 60 gray cover more than 95% of the PTV. And in this case, the normal liver volume was 803 cc. D means was 22 gray. The bowel maximum dose was 48, V45 0.7, and others OAR met the criteria of our constraints. I summarize the treatment course here. So this case had locally advanced HCC. He received 60 gray radiotherapy during the initially and had the grade 1 fatigue and grade 1 anorexia during the treatment. And the blood test we see, there was an elevation of liver enzyme initially, and then decreased slowly after that. After completed radiotherapy, we initiated sorafenib for him. So there was a grade 2 elevation of liver enzyme during treatment. He was taking sorafenib for 3 cycles. After the 3 cycles, we tried to apply the TKI for this patient, but was rejected because the image show no more protovein thrombosis. So we keep follow up these patients on CT scan. Here show you the CT scan taken during the follow-up period. There was no evidence of disease by 1 year. However, 1 year, 5 months, on the CT scan, we can see there was a new lesion. There was a local recurrence over the S6 lesion, S segment 6. And we performed laparoscopic RFA for him. And now patients have no more active disease until 2 years. And the CT scan he took 4 days ago, still in complete remission. Now the patient survived for 3 years and 8 months. This is a patient treated 4 years ago. And in the past 4 years, we know there's a lot of advancement in the past 4 years. In the past 4 years, we have more precise radiotherapy, including SBRT, and prothrombin therapy is more accessible in our country. Now we are in the era of immunotherapy. So I will share the systemic therapy from the landscape of treatment. We can see in these 2 years recently, we have immunotherapy combination. In 2020, we have an amazing combination of atezolizumab and bevacizumab and achieve a median survival almost 2 years. And in last year, we have dual immunocheckpoint inhibitors combination and achieved a median survival about 60.4 months. So revisit the systemic therapy for our case. If the patient is a candidate for systemic therapy, I think the first line systemic therapy would be the AB combination or dual immune checkpoint combination. Both are category 1 on NCCN guidelines. If money is not a concern, I think in this case we have other considerations because these patients got AS and autoimmune disease or active autoimmune disease were excluded in the IO studies. So the data for this group of patients is limited. And we also have to pay attention to the serious toxicity during immunotherapy. So last, my take-home message was RT plays important role in locally advanced HCC. And during the treatment, I think careful pre-treatment evaluation is always important. For huge tumor, we use modified SIB to treat these patients and look quite feasible, but need more evidence to prove it. Nowadays, we have powerful RT technique and also novel agents in advance. So thank you.
Thank you for your presentation, Dr. Zhou. Do you have any question, Jen?
No, I was just going to point out, I loved your summary at the end of where we've gone, and I think HCC has had quite the leap of advancements in terms of systemic treatment options, I would say in the last decade or so. And you know, we do have an ongoing clinical trial with Genentech where we're combining atezolizumab and bevacizumab with radiation. I think the case that you presented is something that would be like a perfect candidate for the studies that we're looking at to explore this combination and how to integrate. So I think I don't know much beyond the IO and the TKIs. There's nothing else in beyond those two classes I think that is truly exciting that I think in the systemic therapies, and a lot of the trials coming out are just now looking at Me Too drugs or combining treatments. But definitely how to integrate radiation I think is a very, very important question. And like Dr. Chan just argued in the other room, I think these advancements just support even more of a role for radiation and not less, that we don't think that oftentimes that one will supplant the other, but just it's all about how to better integrate moving forward. So I thought it was a great case.
But the SIB for HCC is not really common. Could you explain why you decided to use SIB to have the high dose in central of tumor and lower doses for the peripheral?
And in this case, because this patient have very big tumors, and we understand that if we can boost up the BED to go higher than 100, then the control would be good. So we have some experiences before in our center, and for this case, we also tries to use this method to treat this patient to escalate the dose for him. Yeah.
But if the patient got approval of sorafenib or lenvatinib before you gave radiotherapy, how would you sequence the treatment? I mean, what first? SBRT first, or sorafenib first, or in between?
Normally, we avoid to combine these two, combine radiotherapy together with TKI. most of the time to avoid the toxicity, because we know the toxicity of combination will be a concern, or we have to modify the dose of radiotherapy if we want to do it together. So normally depends on the patient's condition. If the patient is very suffering from local symptoms, maybe we will deliver radiotherapy first. And in this case, because this patient will suffer from the abdominal discomfort already, and by the time we still apply for the medication. So during this period, we start the radiotherapy first and wait until the RT finish, and we initiated the medication after patient stable.
What would you do, Jen?
So, you know, Laura Dawson just presented her work for RTOG 1112. That was the randomized trial of sorafenib plus or minus RT. And while the trial actually did not meet target accrual because sorafenib fell out of favor in the time frame of the trial, even with a decreased accrual and adjusting the stats to have more events, there was a benefit seen with radiation in the setting of sorafenib. So I would consider it standard of care now to consider radiation in the setting of sorafenib. Now, no one's super excited about sorafenib because the response rates are quite low, and but I would say that I definitely agree. I think radiation makes sense in this setting where there's tumor vein thrombus and you're trying to get a hold of it. Where sorafenib alone, I think, is probably not that effective.
Okay. Any question from the floor? Okay, thank you for your presentation. Thank you. And next we'll have Dr. Wu to present her cases and for your comments and questions.
So I'm going to walk through just a few cases, really two settings, and I would love to really hear what you guys do here in Taiwan. This is not meant to be a didactic. I know it's the end of the day, but I would love, there's definitely practice pattern differences, and I think that's where a lot of the interesting commentary and advancements can come through. So at MGH, we have quite a robust, multidisciplinary tumor setting, and this is, in particular for pancreatic cancer, we have a very high volume pancreatic, cancer surgery, and so patients come from all over the world for some of our surgeons. So this is a 68-year-old female who presented to the ED with right-sided upper abdominal pain for 1 month, radiating to the back. She was treated with omeprazole and prednisone for back pain, but without improvements, and everything otherwise went unremarkable. And so this is what the imaging showed on CT. And you can see on the left, you'll have an axial, and you can see pancreatic ductal dilatation. That's what we're looking at in the white arrows. That suggests there's an obstructive process. And then on additional imaging, you can see the portal vein, which is narrowed from an infiltrative mass. And then you can see around sort of the other vessels, including the SMB and the SMA, that there's some haziness. And then on that axial, once again, on that yellow arrow, you can see that that's around where the common hepatic artery comes into place, and there's also haziness of the common hepatic artery. So the radiologist read it out as a poorly defined biopsy-proven pancreatic head neoplasm with encasement of the common hepatic artery and portal vein, and then an endoscopic ultrasound confirmed adenocarcinoma. So I don't know if you guys have access to the voting through your devices, but based on this imaging, how would you categorize this patient? Would you consider it resectable? Would you consider it borderline resectable, locally advanced but potentially resectable, or categorically unresectable if there was no evidence of metastatic disease on any additional imaging? Okay. So, this is why it's super helpful to have a multidisciplinary tumor conversation with multiple surgeons. At our institution, I think I would agree with, due to the encasement of the portal vein and common hepatic artery, I probably would not think it was resectable as much, but I think either C or D, depending on your surgeon's comfort, I think is very reasonable. I'll go into what we do a little bit more in just a little bit. But once again, this is just, a really nice schema and of just the involvement of the blood vessels, venous involvement to arterial involvement that really define how you would categorize this. And a little bit is based off of just the aggressiveness of your surgeons, whether or not they would do vein reconstructions, whether or not they'll do arterial reconstructions. That would define how you would define it as well. So if we called it locally advanced, what treatment would you recommend first? Surgery, chemotherapy, chemoradiation, or pancreatic SBRT? And I say this, with an acknowledgement that there's a lot of controversy, I think, at large, both in the United States and in Europe and into Asia about what is the optimal approach for pancreatic cancer in general, and in particular, what is the role of radiation for these patients? Wow, so this is a really nice spread to elicit discussion. I think this pretty much highlights, just the range of options and the degree of controversy that exists in this space. I would say that in the United States at large, it's really for locally advanced tumors, just also given the improved efficacy of systemic therapies at large with multi-agent treatments, and just the high predisposition to micrometastatic disease in this population. Upfront chemotherapy is what the far majority of institutions will start with. And so we routinely, even actually in the resectable population where patients have upfront resectable, there is a randomized controlled trial going on right now in the US looking at upfront surgery versus upfront chemo just to address that micrometastatic risk. And so I can tell you, we at our institution would do B, as would many of the other institutions. But I think, recognizing that there is quite diversity of treatment recommendations. In the US, there's been an increasing uphill battle of the role of radiation at large. Especially, there was a recent study from the Alliance trial that was borderline resectable, and it was FOLFIRINOX plus or minus SBRT. And that was not only negative, but patients did worse than historical controls. So that's really put a damper on SBRT at large for patients that are potentially resectable. Sorry, did I do that? Oh, okay. Okay, yeah. So given that I'm saying that, in our institution or in many institutions, we would start with chemotherapy, which treatment would you recommend, and what would be standard of care here in Taiwan? It'd be fascinating to know. And it might not be any of these, but. Great. So yeah, I think similarly, this shows all very reasonable options, to be honest. You know, I would say a lot of institutions, including ours, have over time leaned towards FOLFIRINOX, just because that's been shown to have the highest response rates, although FOLFIRINOX and Gem/Abraxane have never been compared head to head. And, you know, FOLFIRINOX is a triplet versus a doublet. And so, you know, I think tolerability is a little bit different. But in patients that we're looking for a response, if there's vessel involvement, there's actually, you know, once again, there's good metastatic data, there's good adjuvant data now. It really has become, for many institutions, a standard of care. I think Gem/Abraxane is also very reasonable. You know, there can be some geographical biases, one or the other. And then Gem/Cis/Abraxane also, you know, I think really compelling data of high response rates. You know, it just read out SWOG in the biliary setting. It was negative compared to Gem/Cis. But Gem/Cis/Abraxane does have a higher reported rate of toxicity. So not perhaps as universally adopted. But, you know, I think this is all very, very reasonable. So, you know, if she were treated at Mass General, she would, as I mentioned, our standard is FOLFIRINOX if they're well-performing patients who don't have other contraindications to receiving triplet chemotherapy. And so restaging scans demonstrated partial response but persistent haziness around the common hepatic artery. There's a response with the CA19-9 being lower. What would you recommend at this point in time? So FOLFIRINOX is given every 2 weeks, so this is about 2 months after initiation of chemotherapy. What would you recommend? Would you recommend continuation of chemotherapy? Would you switch gears at this point to chemoradiation? Would you consider pancreatic SBRT at this point, or surgical exploration? So really, once again, a really nice spread. And I think there's not an absolute right answer. Once again, in pancreatic cancer, really, it's a dealer's choice, to be honest. I mean, I would say most people would start with chemotherapy, but I always tell my patients, if you know, within Boston, you have Mass General, you have Dana-Farber, and there's Beth Israel, and the same patient can get three opinions within a span of a week and get 3 different recommendations, all which are correct. So I think that's where you really just need to sort of feel comfortable with your recommendations. I think, you know, it really depends on tolerability, but I think if our patients are tolerating treatment well, our standard and our recommendation would be to continue chemotherapy. I think most of the data in the neoadjuvant setting is up to 6 months of treatment, but traditionally we've done like 4 months and given sort of credit for 2 months of chemoradiation. But, you know, oftentimes if tolerability becomes an issue, then we do have to think about switching gears. Once again, I think pancreatic SBRT is really evolving, and no one, you know, I do a lot of work with Joe Herman, who was a real pioneer of pancreatic SBRT, and with the Alliance trial just being negative, no one really knows where to move it forward. But I think, you know, once again, all very reasonable, and I think it ends up being a conversation with your surgeons as to what do you think the endpoint of all of this is. So I'm gonna actually just skip over this. I think, you know, I think this is the same question, just reiterating it after 4 months. So I'm just gonna move on. So I can tell you, we did move on to chemoradiation at that point in time. And the scans demonstrate improved but persistent vessel involvement. So if the scans show that there's still involvement of the portal vein and the common hepatic artery, what do you think your surgeons would do at this point? Would they, and your team, would you opt for surveillance? Would you do resumption of chemotherapy? Would you say, look, let's just explore for surgery anyway, or would you move to a clinical trial at this point in time? So really nice spread, I think. Once again, I think there's some recognition that we haven't done enough, and so we probably should do something more. And I can tell you, based on one of the things that's been really interesting, and I would say our surgeon, Christina Ferroni, was probably one of the first to do this, is after FOLFIRINOX and chemoradiation, and the scans look horrific with still persistent vessel involvement. I remember she actually got a lot of slack because she took the patient to surgery. And she did this meticulous dissection where she just kept biopsying around the blood vessels, and she sent it over and over and again to frozen pathology, and it just came back negative, 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 negative. And so after that, it's been adopted pretty much, and she's been published on it, MD Anderson's published on it, that actually after chemotherapy, multi-agent chemotherapy and chemoradiation, your imaging is actually not reliable at all for residual tumor, and that the far majority, and we've had two, one for borderline, one for locally advanced, phase 2 trials that we've published in JAMA Onc that have shown, and even in the locally advanced where you have like this patient, more than 66% of patients are able to have the tumor resected with an R0 resection. So I would say that, given the degree of vessel involvement, this patient at MGH would be explored. And this patient was in fact explored. Once again, that means a third of patients are explored and are not able to be resected, in which case we do offer intraoperative radiation. And that's one of the benefits of intraoperative radiation. It allows our surgeons to be aggressive. But this patient did have a Whipple and had a pathology of a YPT1N0. And so my last question for this case, what next? Observation, adjuvant FOLFIRINOX, adjuvant gem-cape, or ctDNA, and chemo if positive. Once again, a really nice spread of responses. No one knows, to be honest. I can tell you we would probably sit tight at this point in time. The patient's gotten a lot of treatment. There are purists who would say, and there are medical oncologists in my own hospital who would say, standard of care after surgery is adjuvant FOLFIRINOX, and they would try to get in 6 more months of FOLFIRINOX. I think a lot of, that's probably a pretty beaten up patient by the end of that. And there's been the SPAC3 data really supported gem-cape. I mean, ctDNA obviously is very interesting. Actually, in our experience, ctDNA does not have a high rate of positivity after pancreatic cancer for whatever reason. But I think, no one knows. But I think all very, very reasonable and a good question to ask. Okay. So this is just an extension of that case where it was much more locally advanced. And I'm just going to sort of skip through this because I want to get to our other case. And I really love, actually, thank you a lot for the participation. I think it makes it much more interesting. We determined this to be categorically unresectable, which the surgeons, because it looks like an eye of a hurricane, the surgeons were very definitive that it doesn't matter what kind of response you're getting, I'm never going to explore that patient, that it's not coming out. And question of early carcinomatosis. I think these are the cases where I think it really begs the question, the borderline patients, I think radiation in the US is losing traction a little bit, although there's really good data with the pre-OPANC. But given the alliance data, I think there's less enthusiasm. But I think where we probably can gain traction is in this categorically unresectable, locally advanced population, where we have not yet proven it. But I think that the medical oncologists and surgeons are much more accepting of the role of local therapies for this population after establishing control. I'm not going to do that. So laparoscopy was performed. I don't know if you guys routinely do laparoscopy here for our patients. I think you know, depending on where the tumor is, laparoscopy. I would say similarly, our surgeons don't love doing it. It takes up OR time, to be honest. And they always say, it doesn't really matter, you're gonna start with chemotherapy anyway, so why don't you just go ahead and do that, and then if it blossoms, well, then you know. But the patients received FOLFIRINOX for 8 cycles, and there's still persistent involvement afterwards that is quite marked. And so, you know, at this time we decided the tumor was categorically unresectable. So I think at this point, you know, what would you do next? And I will ask you to answer this one. Would you just say, let's continue FOLFIRINOX, because this is never coming out and there's really no role? Should we switch to a different chemotherapy, Gemabraxane? Would you do conventional chemoradiation? Or would you consider dose-escalated radiation? Great. So I would say, once again, we're in a data-free zone a little bit. I think all of the above, including A, would be reasonable, to be honest. You know, and there's going to be different practice patterns. I think, you know, I would say to switch to Gemabraxane, you could think about that if you're trying to still get to surgery. You know, if the patient's responding to FOLFIRINOX, I think there's only so many active lines of treatment. I think we tend to not want to give up an active line because it's not like we have gazillions left. So I think our medical oncologists would probably, if we weren't going to switch to a local therapy, continue, or just, yeah, probably continue on FOLFIRINOX until there's progression. And then I think between conventional and dose-escalated radiation, you know, I would say there's probably more and more data that's emerging that does show that BED can be that matters in terms of local control. There's been nice work from Sunil Krishnan's group. Chris Crane has a JAMA Onc paper looking at 15 or 25 fractions of dose escalation. I think, you know, if you look at published data from different institutions, I think if you can get to a BED of like the 90s to 100s, then you can get pretty effective local control. And I think once again, but in, you know, when we talk about dose escalation, you have to think about volumes, and, you know, that's a lot of area of controversy. Do you do elective volumes? Do you not do elective volumes? You can't obviously do dose escalation with, you know, with elective coverage. But more and more groups are reporting fairly high rates of local failure or local regional failure if you do GTV alone in the, I think, in the setting of FOLFIRINOX. So it can be tricky. Okay, so that's the end of my pancreas discussion. I don't know if anyone has any comments or thoughts they'd want to share before I move on. Okay, so I'll go to the second case, which is talking about rectal cancer. I think this is where there's also a lot of different practice patterns that are emerging, because there's a lot of randomized data that is coming out to support a lot of different paradigms. And I used to tell my residents, we know what we're doing for, we might not know what we're doing for pancreatic cancer, but we know what we're doing for rectal cancer, because I would just tell them the German rectal, just know that study and you're good. And now I'd say everything is up for grabs. And a lot of studies are trying to drop one modality, chemotherapy, radiation, or surgery. And then a lot of it is about sequencing. How do you order the deck chairs? And so this is a 40-year-old, my case is a 40-year-old premenopausal female who had bright red blood per rectum for 1.5 years and increased bowel frequency. There was an ulcerated rectal mass approximately 7 centimeters from the anal verge, and pathology demonstrated moderately differentiated invasive adenocarcinoma with no evidence of metastatic disease seen. And this is the imaging. You can see there is a rectal mass, and you can see a perirectal lymph node right at the edge of the mesorectal fascia on the left. Once again, more mesorectal lymph nodes. There's some stranding beyond the muscularis propria that makes it T3, node positive. And this is the sagittal imaging. You can see quite a long stretch. So it was T3, node positive. Threatened mesorectal fascia with tumor within 1 to 2 millimeters of the mesorectal fascia, no sphincter involvement, no EMVI. So my question for you is, what would you recommend as the treatment paradigm for this patient? Would you recommend short course, then chemo, then surgery? Would you do chemo, then short course, then surgery? Would you do long course chemo, long course surgery, or would you do German rectal? Very nice. So yeah, once again, all very reasonable answers. And I'd say the same thing as I did for the pancreas. You can go to 3 different institutions in Boston, all within the Harvard system, and get 3 different opinions, all that are equally correct. So, you know, the first one, obviously, that is representative of Rapido trial that came out not too long ago, and high-risk population, and, you know, was positive for, you know, disease-related treatment failure. So a very reasonable standard of care. Long course chemo rads followed by chemo, followed by surgery. Once again, very reasonable. I would say D is, you know, depending on what the chemo, and I think I asked that in a separate question, the PRODIGE is the FOLFIRINOX data, followed by chemoradiation, also compared to the German rectal. So the PRODIGE and the Rapido came out around the same time, so established 2 very reasonable standards of care. And then in terms of sequencing of chemo rads versus chemo first, lots of, you know, there have been randomized phase 2 studies looking at sequencing, and then more recently the OPRA study in the non-operative setting. I think all very reasonable. What we know about sequencing probably is that whatever goes first will have the higher compliance rate, 1. And 2, that the longer from the completion of chemoradiation to when you evaluate for surgery will probably have the most impact or higher impact on clinical complete response rate. So part of the question is, what do you prioritize? You know, are you thinking about non-operative? Are you not thinking about non-operative? How high of a risk do you think is for metastatic disease or not? I think that ends up playing a role. I would say as an institution, we at MGH have gone and tend to do more D. But I can tell you a Dana-Farber patient may be seeing the same exact patient, and they may be considered for Rapido for A. So I think all very reasonable. So what, if the patient is receiving chemotherapy, what chemotherapy would you guys routinely use? Would you do FOLFOX, CAPOX, FOLFIRINOX, CAPE alone, 5-FU alone? Yeah, so I would say that I would agree with the fact that most of the data really is looking at FOLFOX, so I think that makes a lot of sense. Once again, because we love FOLFIRINOX at MGH from pancreas cancer, and FOLFOXIRI, and in the PRODIGE, we do FOLFIRINOX. It's an open question. What is the additional benefit of irinotecan in the setting of non-metastatic disease? I know in the metastatic setting, it certainly increases response rate, but you know, there's no randomized trial that actually shows that benefit. But if you believe in the PRODIGE data, it looks compelling, and we have routinely done it. I would say that at large, though, it should be acknowledged, and you know, some of the argument for not doing FOLFIRINOX or any of these is that really in the adjuvant setting, if you looked at the German rectal, and there have been multiple studies that have looked at the additional benefit of adjuvant chemotherapy, it actually has not been shown to be a survival benefit. So not only are you then moving it up front, but you're also then intensifying it with FOLFIRINOX. So I can argue out of both sides. But, I think, I agree, and our medical oncologists agree, that ultimately, distant metastatic disease is still the main driver. For a 40-year-old who has node positive, you worry about distant metastatic disease. So, there's no way we wouldn't be aggressive with chemotherapy, either with FOLFOX or FOLFIRINOX. And CAPOX is just a sort of a variation of that. I don't know that we would do 5-FU alone. If we're going to give it, we might as well just give the FOLFOX, I think, for systemic but once again, not unreasonable. Okay, so after neoadjuvant therapy, there's been a response, but persistent disease that looks like a T1N0 disease on MRI imaging 1 month post. What would you recommend for, what surgical options are there? An APR, an LAR, low anterior resection, a wide local excision, or would you consider continued observation for further shrinkage? Yeah, so I would agree with this. I would say, we do have, and I don't know how frequent it is here, but a lot of our patients are very proactive and educated, and they come in, and now they know non-operative management is out there. A lot of them come in asking for non-operative. I would say that, this is totally a patient that could have a low anterior resection. If it's a low anterior resection, I have a slightly higher threshold than an APR for consideration, although we still will. But with residual disease for a 40-year-old, I would 100% ask them to proceed with a low anterior resection. I do know that there is a lot of interest among colorectal surgeons about doing wide local excisions or doing sort of less because of the concern for bowel functionality. I would always argue that, even if they have subpar bowel functionality, my primary focus is on oncologic outcome. And without taking out the tumor and there's nodes, if there's still residual cancer, this does not meet the criteria for any kind of sort of, I think, once again, I would be as conservative as possible for this patient, and, standard of care is for an LAR. So, I would agree with that. There is a lot of data looking at wide local excision, and continued observation. We do know time from completion of treatment. Like if you look at anal cancer, we now wait up to 6 months. 1 month is still a little early, but I would say if that is the approach that's taken, definitely is worth a very detailed conversation with the patient and close observation with repeat scopes to just make sure. So I think that's actually it for me. I think that was all of my cases, but I do want to really thank you guys, because I think you guys did a great job in participating this late in the day. So.
For the last case, 7 centimeter above anal verge, is it not easy to do the wide excision completely for that distance?
So there are approaches that they can do endoscopically to do a resection of that area. I guess my concern is, for a patient who is 40, who had nodes at presentation, if they didn't have a clinical complete response on FLEX-SIG or on MRI, I would worry about not only that tumor that we see intraluminally, but what does that represent about the disease and the nodal disease that is not going to be adequately sampled without a TME excision, with a wide local only. I know that there is a lot of data, like for GRECR, that does look at wide local excision. So there's definitely that data that exists. For me, probably a little bit more, I feel a little bit more pushed in that direction should there be an APR on the table, but with a LAR, there can be fairly good functionality. There will be a little bit of a quality of life change and detriment, but with my concern of, optimizing disease outcomes. I don't yet quite have that confidence.
Any question or comment from the floor? Yes.
I have a question about the rectal cancer. In the setting of the neoadjuvant treatment, will the tumor location influence your decision making about short course RT or standard course RT? For example, the tumor site near the sigmoid colon or near the anal sphincter, will the tumor site influence your decision making about the short course and the standard course RT? Thank you.
Yeah, that's a great question. I would say yes, it does. But I would say one is if it's in the sigmoid versus anal verge, I think patients will naturally have more of an opposition towards surgery in that setting. It tends to come up. And if there's an option down the road, if there's even a consideration of non-operative management that could come up on the back end, there's just not as much data for short course as there is for long course in the setting of non-operative. Now, Washington University has published some phase 2 data that looks promising, but I would say, once again, there's randomized data now in the OPRA setting of long course. I think that's where most of that data exists. So if there's any hint of a possibility that non-operative is going to come up, I would favor long course, and it tends to come up more in that anal verge area than a sigmoid tumor. Although I recognize that the pathologic complete response rates in the Prestige and the Rapido were both equivalent. And so short course followed by chemotherapy can lead to very effective, but if you look at local control rates actually over time, it actually is it looks like short course radiation does have higher local failure rates compared to long course. So I think it influences me in that way. If there is also, threatened mesorectal fascia, or if there's involvement of mesorectal fascia, I also tend to favor long course just to optimize. I would, for like T4 and 0, I would do chemo rads first, and then chemo, and then surgery to optimize downstaging.
Any question? One last question. What is your experience if your patient has very distal rectal adenocarcinoma, receiving neoadjuvant chemorad, and partially response? So the next decision will be like APR, but the patient just doesn't want to lose the anus and just don't want surgery. What would you do?
And they've already completed treatment?
Yeah. Because there are growing data saying that we can wait. We can wait and prepare the salvage surgery. So what would you do?
Yeah. I would say it can be, I would say my comfort level if there's still residual disease after neoadjuvant treatment, I think it's a very thorough discussion. Usually, I think over time we can convince patients to get an APR, to be honest. So that comes up rarely. It's not come up never, though. And I think if they are informed about the risks, I'm okay with watching. But I document a lot. And I think I've had patients who are younger, who for very understandable, similar quality of life issues, they have refused recommended surgeries. And, some of them have recurred locally and ultimately had distant mets and they've died. And that's hard. It's hard when, in that moment they understand that quality of life is really important, but they may not also always appreciate the full impact of what local persistent disease can mean for their quality of life. So that, I think that's where we have very long conversations with our patients. Now, it may seem like we're very conservative. You know, MSK was one of the first to adopt non-operative management. MGH came along later. I think Dana-Farber is probably even more conservative than we are. So there's a whole spectrum of sort of willingness to adopt this. But you know, there's some data from MSK that doesn't 100% suggest that long-term disease-free outcomes are equivalent. So I think they just have to have this awareness and this a very thorough discussion. If they are going to opt to defer surgery, they have to be also very compliant patients. I've had patients who opt for that, are young, in their 20s or 30s, and then are very young of mindset, and so they just disappear. And then they don't get scoped, they don't get MRIs because they think they're young, they're cancer-free, and then they come back with whopping recurrences. So it just has to be entered with a lot of thorough discussion. But I think, you know, if the patient's refusing, then there's only so much you can do. What do you guys do?
Same.
Yeah.
Yeah. Document a lot.
Document a lot, yeah.
Okay, we thank Jen for this wonderful session, and we also appreciate your participation for this session, and we close the session here. Thank you.